we look at organizations that are successful at leading digital transformation. Why? One of the things is because they're great at learning. You've got to make sure that the clinical staff is involved in the creation of this and they're taught about why it matters. It may take several years, but nonetheless, the world will be different.
Last year, when we interviewed John Glaser, Ph.D., his number one piece of advice to leaders was to understand AI and how it will impact the healthcare industry. To follow through with that advice, we brought him back on the Gary Bisbee Show to discuss his new book, Advanced Introduction to Artificial Intelligence in Healthcare.
In healthcare, in terms of image recognition, we're quite sophisticated.
Dr. Glaser defines AI, deep learning, and robotic process automation, providing examples from healthcare and other industries.
The machine, perceives their environment and based on that perception takes steps to maximize their chances of success.
He explores challenges related to selecting and cleaning data, interoperability, and ethics. And he discusses how healthcare leaders should approach AI implementation and accountability.
And at times, data can be the Achilles heel of this, but it depends on the use.
Let's dive deep into artificial intelligence.
Well, good morning, John, and welcome.
Thank you, Gary. It's a pleasure to be here.
We're pleased to have you at this microphone, and congratulations. Your newly co-authored a newly published book, Artificial Intelligence in Healthcare, is just a terrific reference guide, and it needs to be on everyone's desk, all of us who are leaders in healthcare. Let's dig into how leaders could be thinking about this.
Yeah.
And, we interviewed, had a conversation with each other about a year ago on this show. And one of the advice you gave to up-and-coming leaders was pay attention to AI. You need to really learn about it. And how does that advice look today, John?
Well, Gary, I think it still applies today. It's maybe almost timeless in some ways. I think, the book was written from the perspective of, let's presume you're in front of the C-suite of a health system or the executive committee of a health system. What would you say if they ask you about, well, what should we do about AI? And that's sort of the framing that led to the book and its contents, et cetera. And I think, Gary, about every 10 years, a technology arrives that truly changes the world. And so, I've been around long enough to have seen a number of them, the network PC, the internet, the mobile device, the sensors everywhere connected, and AI falls in that category. It may take several years, but nonetheless, the world will be different, just as the world's different because of the internet and because of mobile devices. So it will factor into the activities, the care delivery, the operations of any health system in a material way. So you better begin to understand it and begin to learn about it, et cetera. And I think one way to start with that is say, well, what do we mean by AI? Within that, there's really two broad categories of AI. One is referred to as deep learning. And basically what happens here is you feed the computer an awful lot of data and it classifies what it finds. You feed it a bunch of images of MRI images and it says, I think there are tumors and this is the type of tumor that I see. Or you feed it a bunch of data that suggests kids with asthma and it says, I perceive this kid's well managed, this kid is not, et cetera. So it gets pretty detailed. So it can tell you, for example, not only that this is a car, but the make and model of the car. Facial recognition is an example. We came back from a vacation in Bermuda last week. I went into Global Entry. It took a picture of my face and it knew exactly who I was based on facial recognition. So deep learning is one example. The second is what they call kind of an odd term, frankly, robotic process automation. And there the computer is watching a process, and the process could be prior authorization. The process could be coding a medical record. And it's as long as that process is working like it should, it's silent. But if it detects that the process is off course or likely to be off course, it intervenes and suggests that here's what we ought to do to make sure that the process goes back to where it should. And so these can be a number, often administrative processes that go on, care coordination, readmissions, et cetera, are examples here. So those are the two major categories that are going on. And broadly, Gary, they fall into the category, the overarching family, so to speak, of statistical pattern recognition, like regressions, like cluster analysis or factor analysis, things that you and I might have learned in college or graduate school. AI is an example of that. But nonetheless, it is going to be, and in some ways is, quite profound, changing industries and will continue to do so for years to come.
John, how does AI in healthcare compare to other industries? Sometimes those of us in healthcare think we're behind in certain technology applications, but is that the case in terms of AI, do you think?
In some ways, it's really hard to say where are we because it's so diverse. We're ahead here, we're behind there, et cetera. In healthcare, in terms of image recognition, we're quite sophisticated. Where the machine and where a lot of the work is how do I know in a radiology finding or an ultrasound finding or a video of somebody whether they have Parkinson's or not? Can I detect that? So we're quite sophisticated there. We're also pretty sophisticated in a lot of linking together of instruments and devices and saying, by the way, I'm in the ICU and this is the pattern that I'm seeing here. We're not as sophisticated in other types of things, which is, managing what's the likelihood that Gary's going to be healthy in the year ahead. We're still crude in some ways.
Are we in danger of overhyping AI at this point? Sometimes we hear it can be used in certain ways that sounds like Star Wars.
Yeah. Well, and I think you get these examples where you won't need humans as doctors anymore. You got a robot doc that's got to go on here. So there is hype and there's some fascination with that, and I get it. It's pretty exciting. Matrix type movies and things along those lines. Example was a study done that looked at predictive algorithms for COVID early in the pandemic, and the algorithm said, "Are you likely to get sick? And if you do get sick, how severe is it likely to be?" There are 200 algorithms that came out. None of them were clinically useful. So it was overhyped, but it turns you sit back and say, what was that all about? Just not very useful. So yes. And I think one of the challenges for the leadership is, okay, it's overhyped. I got it. And we're also at times inappropriately dismal about it, but it's going to get to mature use. So how do I navigate my way through this period of time of a lot of noise, frankly? And, I don't want to overbet the farm, but I also don't want to undersell the stuff because it will be important.
John, you talked about data and the importance of data. Can you talk about the difference between data and then what I might call clean data, which seems to be a big problem here?
Two examples here. One is a pretty famous study that was done that said, I'm going to look at individuals and see to what degree are they going to be really sick in the year ahead. And if they are, or my algorithm says, I'm going to focus on them, et cetera. So it looked at a lot of data, but one of the pieces of data it looked at was how much did it cost to take care of you last year? And it assumed it would cost that to take care of you next year. What it forgot to think about is that if you're poor in rural areas, your costs are really low. You don't have access to care. That doesn't mean you're not really sick. So the algorithm was biased towards people who had access to care and towards people who actually who were covered by insurance, et cetera. So the data was clean, but it was wrong in certain ways. The other is you can have, you say, all right, I want the AI to look at a bunch of images and this is a tumor and this is not, et cetera. And I say, well, how will I know? Well, I'm going to ask a bunch of physicians. Do you see a tumor or not? And I'm going to use that to train the algorithm. At times, physicians don't agree. And so, the way you label the data is different, et cetera. So the data is not wrong. It's just interpreted differently. So there's all kinds of stuff you have to wade through on the data. Sometimes it's a real big issue and sometimes it's not.
Yeah. John, the book makes the point that there's two broad uses for AI. One you call administrative payment, and the other is clinical. On the administrative payment side, what are the low-hanging fruit? Where has AI been used and has been effective?
By and large, what you find, and one of the points is it's probably further ahead in administrative than in clinical. And one is the ROI tends to be clearer in the administrative. If I can improve coding, well, that's a clear return to me. And if I can do a better job of reducing the cost of prioritizations and not getting it wrong, there's real return here. So that's a little easier. If I have, a doctor who's better at diagnosing images, what's that worth to me? It's a good thing, but it's a little harder to put your finger on the return on it. So the ROI tends to be clearer. The second is that the mistakes, if you make mistakes, it's less consequential in the administrative area than in the clinical. And because of that, they're unlikely to be regulated in the administrative than they are in the clinical, which means leadership will tend to be less hesitant to go after them and, not saying what are the regs and whether we step in something. So lots of great examples in administrative, very diverse, and it's tend to moving faster than we see in the clinical.
Mm-hmm. You used examples of predictive modeling on the clinical side. How important is predictive modeling on the administrative side, John?
Well, it can be, it can be depending on their type of use. The predictive, you have to give you an example, Gary. It's sort of a lot of what you see is sort of in the boundary between clinical and administrative. I have a colleague who works for a large health plan, and they were looking at trying to reach out to their subscribers to encourage them to get vaccinated, for the COVID. And they found that in the sample that if you take 100, some percent, let's say a third, they're going to get vaccinated no matter what you do. You don't have to do anything. They'll go off and do that. And there's another third that aren't going to get vaccinated no matter what you do, for whatever set of reasons they don't believe it's true. And then there are a third that are persuadable. And they're trying to figure out who's the third that are persuadable. I'm trying to predict whether you are amenable to a conversation or not. And so that's in this boundary between clinical and administrative activity.
What about cybersecurity? Does AI help or open the door for more cyber issues?
What can be striking, Gary, is, take a large health system. How many people try to get in to their network on any given day? It's tens of thousands, times hundreds of thousands. And just sort of sorting through all that at times requires AI to know when I, as a security person, need to intercede. So AI per se, I don't think creates additional security risk. It helps you combat it. The major risk with AI, some of which you just talked about, is what I call algorithm risk. Is you think you've got the right set of data, but you don't. You're skewed in some ways. Or you forget that data decays. So if you did have the cat's pajamas of the COVID algorithms, in the year 2000, even if it was great and really predictive and all that stuff, it isn't anymore. Why? Because the variants are different. The treatment patterns are different. So the world changes. And because of that, the data you trained it on is no longer reflective of the reality of today.
Let's turn to the clinical side for a moment. You indicated that imaging is perhaps the most prominent use clinically at the current time. Is that true, John?
If you look at the FDA's blessing of AI use in a piece of diagnostic equipment, the vast majority are radiology. And the thing that works great with radiology is one of the things that AI works well. If I want to train my deep learning algorithm to recognize this out of the other, I have to be able to say, did it get it right? And if it didn't get it right, how do I tune it? One of the neat things about imaging is if the AI says there's a tumor, you can inspect and say, you're right, or you're not right, et cetera. You got a way of determining truth, or fact. If I say you're likely to live next year, it's a little harder for me to know whether that's going to be fact or not.
What do we know about how doctors use the outcome of predictive modeling? You can see that in some cases they might say, hey, predictive modeling is trying to override my decision-making as a doctor, and others would say, well, that's just more information that's useful for me. Where do we stand generally on that point?
You've got to make sure that the clinical staff is involved in the creation of this and they're taught about why it matters. You got to make sure that it's into the workflow so it's easy to listen to, et cetera. You got to make sure you don't over alert. It's the same thing with the AI algorithms. They're quite willing to be, someone suggesting there may be something going on here you pay attention to, but you got to introduce it well. And you got to make sure that it doesn't take 5 extra steps to go off and do it. And you got to make sure you don't badger them into the point where they say, enough already. I'm just trying to take care of patients.
What about liability in terms of the vendor, the physician, the institution, and so on? Where does liability fall in this whole area?
It's like writing a textbook. You better make sure that if someone says, wait a minute, this is wrong, you say, yeah, but I did all the things I'm supposed to do. Talk to experts, reference, et cetera. I want to show professional diligence. So liability can rest with the supplier to the degree that they didn't exercise it. On the other hand, liability can also rest with the consumer of the textbook or the consumer. That is, if you could say, listen, you're a doctor, you should have said, wait a minute, this doesn't make sense for this particular patient. You did robotic following, et cetera. So those are where the two liability factors can lie, is on the producer, but also on the supplier. And in some ways, it's the same kind of liability equation we've seen with medical textbooks.
So ethics is another issue, and you can see that there could be a variety of ethical concerns. Have we done a good job preparing for those kinds of ethical concerns, John?
Oh, I think we're getting our hands around it, Gary. And you're right, there's a range of them. And you can get, a range that says your data is undersampling certain populations. And so you're missing real issues confronting African Americans or Hispanics, et cetera, or people in rural settings versus urban. So you've steered the care, to ways that disadvantage them. And that's an ethical problem. There can also be ethical problems that you see broadly speaking in digital health that says, I've got individuals, digital therapy is an example, is I can give you a device that helps you, deal with an AI bot to worry about your anxiety or your depression, et cetera. But it assumes you've got a device and it assumes you're in an area where there's good internet coverage. Neither might be true. So I've got an ethical problem of access. Is certain technologies which provide value are out of the reach of certain populations, and we've got a problem.
So you've indicated that AI is really in early innings, if I can use that term, maybe a bit ahead on the administrative side versus the clinical side. From the standpoint of a leader, I mean, should we be thinking about this for the rest of this decade? There's just going to be continued evolution, continued applications for AI.
I do think there's two general things that I would, if again you and I were in front of a C-suite, what would we say? Say one is nobody buys AI; they buy something else that performs better because of AI. So you say, I want some software to help me with utilization management, or appointment scheduling, or diagnostic imaging, and you're the vendor. You say, I have AI. I say, well, why does that help it do any better? What makes the performance gains worthwhile by that? Did to that? I'd ask the same questions that I've always asked of a supplier trying to sell me some software solution. How do you know that it works? Show me that it does. All the kind of stuff here. So nobody buys AI. And related to that is an algorithm is not a solution, which is not a company. So someone might say, I got the greatest algorithm on the planet. I said, I'm happy for you. On the other hand, that doesn't mean that it fits into the workflow well. So it may not be a solution because it's really the only thing that's got to happen. And even if it is a solution, it doesn't mean you've got a company that's got legs, at all this kind of stuff. There are hundreds of AI algorithms related to radiology. The poor radiologist says, I'm overwhelmed here, and so none of them will get real traction because there's just too many. So remember, you buy something else that is better. You buy a car that is safer because of AI. You buy an MRI that's more reliable because of AI. And the question is, you look at more, what am I buying, why, and what does it do? I think the second thing, and I remember, Gary, when in my tenure as a CIO, when the web first came out, we had an internet strategy committee. And it was, what are we doing on the internet? What are we learning about its uses in healthcare, but also, broadly speaking, other industries? And we had that for about 3 years, and then we stopped having it. And why? Because we really understood how to apply it. And it was still early in some ways, but we understood this. So what I think I would do is say, I've got to start learning about this stuff. And when you look at organizations that are successful at leading digital transformation, why? One of the things is because they're great at learning. They just learn all the time. They're out there absorbing what's going on here inside and outside, et cetera. And I'd say the same is true with AI. So I'd start that. You may abandon the committee or disband it 3 years later, but fair enough. For right now, you're learning, and that's the right thing to do, to know when and how it will take off and when and how it will provide material advantage to you. And frankly, some of these are just flashes in the pans. Fair enough. Let's learn about them and, cut our losses and move on.
John, you've addressed this in several different ways. Let me ask the question directly. Should we be looking for AI innovations from larger companies or some of these earlier stage startups?
So I think when you look at AI, there will clearly be stuff that comes through your major supplier of your HR, your revenue cycle, or population health, whatever. But there will be upstarts. And when you see the upstart, your job is to do the homework. It says whether they really have a material leap here. If that's the case, because it happens, these established companies disappear because of guys like this who come through here. Is it really material? And do I think they've got the backing and the leadership talent to make it? And if so, I'll take a shot at it, et cetera. So you'll see it from both sides here. You don't want to be saying, no matter what Cerner Epic does, that's all I'm going to do, because you might be missing some great opportunities. Nor do you want to be overly anxious when an upstart comes along, because not all of them will work out.
Who in the organization, who in the health system is responsible for AI, responsible for that pilot testing and the committee that you made reference to and so on? Who's the focal point of interest and responsibility in the house?
So you have this, fundamentally the CEO and the C-suite's accountable. The CIO can lead the group. I do think the pilots are being held accountable by the, department or area that is holding them, et cetera. And just to make sure that we're learning. So it's like a lot of things we do, Gary, in healthcare. It is, the accountability is shared, because so much of what we do just traverses, all aspects of the health system.
If you were the CIO again, as you were for many years at Partners, what would you want the board to know?
So what I'd want the board to know is a couple of things. One is it's early, but it's a big deal. And so what we're going to do is create this series of pilots and experiments to go off and learn about these. We'll give you updates as appropriate. And when it gets time to hit a home run, we'll talk about that. The other thing is, board, because you know these folks, there's some serious talent around the table. And I'd say I've turned to the person who might be the CEO of the local bank, for example, and say, I'd like to talk to your person who's doing with AI to learn from them about what's going on here. Because yes, banking is not healthcare, but there's a lot I can learn about how you think about it and how you do it, et cetera. So I'd like to really leverage your organizations as appropriate to go off and do that. But again, we're in this learning exercise. We're not ready to bet the farm on this thing. And I'm not ready to sit here, I want $1 million or $10 million or $20 million to go full. I may come there, but I'm not ready to do that yet. That's kind of what I'd want them to know.
Okay. John, this has been a terrific interview as expected. You are so knowledgeable in this space. I'd like to ask one last question, if I could, which we asked a year ago, and that is, for up and coming leaders, what would you like them to, what advice would you have for them about AI?
Yeah, I think the main thing is to be able to take the time to understand it at a level that says I can have just like we're having now, this sort of conversation now, and to take the time to think through how might I apply it here. And that may be ideas they have. It might be, golly, I went to a conference and I saw what other people in the operating room management are doing about this stuff, et cetera. How might I think about doing this thing? And I also might say part of your job is technology can really change. We've seen industries transform and organizations transform. Your job is when these technologies arrive that can truly change the nature of your work and what you do, you ought to be on top of that. So I'd like you to learn enough about it, learn how to apply it, and then if you think there's some ability to really improve what your group does, is that you begin to put those ideas on the table here.
John, thanks for being with us today.
Pleasure.
Okay, artificial intelligence in healthcare. It's a good one. Should be on every leader's desk. Thanks, John.
All right, Gary, you take care, and I'm glad to spend time with you.
Okay, cheers.